I'm Jen Kamel, VBAC Facts founder. And since 2007, our focus has been to provide accurate and objective information on vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers, and the court, so all decisions can be informed, ethical, and just. Today, we'll be talking about informed decision-making and who makes the ultimate decision on VBAC versus repeat cesarean, as well as the myriad of other decisions that people get to make during pregnancy and labor. This topic generates the most lively discussions during my live trainings, and I have to say I understand why. There is a lot at stake. And there's also questions about who has the right and responsibility to make these decisions. Now, I've touched on this topic in the past in prior episodes, but I really wanted to dive into it more because I find that, again, looking at what the American College of OBGYN says about informed refusal sheds a lot of light. And it can be really surprising how many people who work in healthcare, as well as how many people who are birthing, are unaware of these ethical principles within healthcare. So before we dive into that topic, I wanted to share a few wins, and I would love for you to share your wins with me at vbacfacts.com/podcast, and I may share it on the podcast. But this latest win was from a reader who left me this question. She said, feet size 2.5, I'm 4'11", C-section first time, and OB is saying I need another C-section. So this was a question that I posted on social media, and I invited other people to share their story, other petite birthing people and women to be able to say, this is how tall I am, this is how big my baby was, just to show that it is possible. Because again, that's one of my objectives with this work in general, and with this podcast specifically, is to show other people what is possible. So let's see what readers said. So our first comment is from reader Diana Snyder, who is a doula. And she says, one of my most inspiring clients is 4'11" and has had 2 successful VBACs. Both were challenging labors, but she had a very supportive provider. Her second VBAC baby was over 8 pounds. I'm not quite that short-statured, but I am 5'3" and VBAC'd as well. 14 hours, he had a 99th percentile head and still does. Vicky, who is a midwife, said, my ex-mother-in-law was 4'11" and vaginally birthed 4 babies, none of whom was less than 9 pounds. Not a direct correlation between height and pelvic capacity. Terry says, the biggest baby I ever delivered was 10 pounds, 12 ounces. Mom was 4 feet, 8 inches. Normal delivery. Reader Amy shares 5 foot, 108 pounds, 4 pound, and 14 ounce baby. Unmedicated vaginal birth, no tears. Reader Jennifer says 5.2, and she had a vaginal birth after 2 cesareans. Reader Sharon shares, your height and weight have very little to do with birthing vaginally or not. My most petite clients tend to birth the largest babies. I'm only 5 foot and had 2 VBACs, but was basically told the same thing. CPD was the diagnosis after cesarean. Reader Catherine says, also 4'11" and have had 3 successful vaginal births after 4 cesareans. One of them was 9 pounds, 5 ounces, and 21.5 inches. There are tons of comments on this thread, and I'm going to include a link to it in the show notes because if you are short-statured, this might give you a little bit of encouragement about what is possible for your next delivery. And again, just because you had a C-section last time doesn't mean that predicts the future for all future deliveries. So, on to the main topic of today. So I have in front of me ACOG's committee opinion. Number 664 was published in June of 2016, reaffirmed in 2019, and it's entitled Refusal of Medically Recommended Treatment During Pregnancy. And I almost always have this document linked in the show notes because this topic is almost always discussed in every single episode. The abstract reads, one of the most challenging scenarios in obstetric care occurs when a pregnant patient refuses recommended medical treatment that aims to support her well-being, her fetus's well-being, or both. In such circumstances, the obstetrician-gynecologist's ethical obligation to safeguard the pregnant woman's autonomy may conflict with the ethical desire to optimize the health of the fetus. Forced compliance, the alternative to respecting a patient's refusal of treatment, raises profoundly important issues about patients' rights, respect for autonomy, violations of bodily integrity, power differentials, and gender equality. The purpose of this document is to provide obstetrician gynecologists with an ethical approach to addressing a pregnant woman's decision to refuse recommended medical treatment that recognizes the centrality of the pregnant woman's decisional authority and the interconnection between the pregnant woman and the fetus. The reason why this document is so powerful is not only does it walk us through these various ethical quandaries, but it also guides how do you navigate it? What are the specific steps? How do you manage a bad outcome? How do you interact? And when I say manage a bad outcome, I mean, how do you manage it emotionally after the fact? How do you communicate that to the patient? How does the team come together after that? What does the debrief look like? What does support look like? And so, if you are working in L&D and you are not familiar with this document, click the link, download it, read it. It may very well impact the kind of care you offer, as well as how you navigate these circumstances. So ACOG says when a pregnant woman refuses medically recommended treatment, her decision may not result in optimal fetal well-being, which creates an ethical dilemma for her obstetrician gynecologist. And in such circumstances, the obstetrician gynecologist's ethical obligation to safeguard the pregnant woman's autonomy. So the first paragraph in this document is a reiteration of the abstract, but the last sentence in that paragraph really brings up an important point that we may see reiterated throughout this document. And it says coercive interventions often are discriminatory and act as barriers to needed care. And if we look at any application of interventions, we will very likely see a racial disparity. And this is why it's really important to measure outcomes, to keep track of outcomes at your facility, so you can see whether there is a racial disparity at your facility, and then you can address what is behind that. And you can go into a period of discovery and try to really examine and ask questions of where does that racial disparity come from, and how can you eliminate it or shrink it as much as possible. So the purpose of this document is to provide obstetrician gynecologists with an ethical approach to addressing a pregnant woman's decision to refuse recommended medical treatment that recognizes the centrality of the pregnant woman's decisional authority and the interconnection between the pregnant woman and the fetus. This document is not intended to address professional liability or legal issues that may arise in association with decision-making when a pregnant woman refuses medically recommended treatment. Okay, let's pause there. We've talked about this concept before, but I want to reiterate it again. One of the ways that providers and clinicians can protect themselves from liability is honoring informed consent. And informed consent fundamentally means that pregnant person is informed about the risks and benefits of their situation. The clinician provides a recommendation for what they think the appropriate course of action should be. And then the clinician supports the patient as they make an informed decision. With that process of understanding the risks and benefits, hearing the clinician's recommendation, and exercising their right to make an informed decision, comes the responsibility for the outcome. So ultimately, it is the pregnant person who holds the responsibility for the outcome and not the clinician. Now, that's a very brief synopsis of this larger topic, but that is how we are able to meld together true informed decision-making, respectful, evidence-based, and ethical healthcare, and also reduce legal liability. Now, of course, this is going to require a further education of the court, of attorneys, and really us all collectively looking at healthcare in a whole new way, as seeing clinicians as lifeguards rather than gods who can promise a specific outcome. Okay, let's continue. So information regarding professional and legal issues is available elsewhere, and they point to ACOG's documents on professional liability. So, recommendations. On the basis of the principles outlined in this committee opinion, the American College of Obstetricians and Gynecologists, the college, makes the following recommendations. Pregnancy is not an exception to the principle that a decisionally capable patient has the right to refuse treatment, even treatment needed to maintain life. Now, the key thing here, and ACOG's going to talk about this in a little bit, But the reason why is because no one can see into the future. And so ACOG's going to reference that later, but I just want to add that in there because that is a key part of this whole discussion, is that no one can see into the future. No one knows how an individual labor is going to play out. Even when there are times of higher risk, that doesn't mean there's 100% likelihood of that outcome. So therefore, a decisionally capable pregnant woman's decision to refuse recommended medical or surgical interventions should be respected. Second recommendation, the use of coercion is not only ethically impermissible, but also medically inadvisable because of the realities of prognostic uncertainty and the limitations of medical knowledge. Prognostic uncertainty is just fancy language for saying no one can see into the future. So again, let's look at uterine rupture. The risk of uterine rupture varies from 0.5% to 1%, depending on a variety of factors. Someone will be that statistic. Whether the patient in front of you is that statistic or not, none of us can predict. And even in situations of higher risk, where they might have 2 prior cesareans or 3 prior cesareans, we can again look at the available evidence. 3 or more prior cesareans, we can look at the very limited evidence available. And we can include that in part of the decision-making process, but no one can look at that individual person and say, you are going to experience this specific type of outcome. Let's continue with what ACOG says. As such, it is never acceptable for obstetrician-gynecologists to attempt to influence patients towards a clinical decision using coercion. Obstetrician-gynecologists are discouraged in the strongest possible terms from the use of duress, manipulation, coercion, physical force, or threats, including threats to involve the courts or child protective services to motivate women toward a specific clinical decision. This is a key quote because I see this happen. I probably see this happen more often than most people because I am more likely to hear these stories because these people come to me. And so often, this sort of interaction happens behind closed doors. So unless the birthing person goes out and tells someone about it, unless they contact an attorney, unless they contact the media, unless they file a claim, often these kind of interactions, they go unseen, right? Because there's 2 people in the room or 3 people in the room. And so ACOG is saying, no matter the circumstances, you shouldn't be threatening people with a psychological evaluation. You shouldn't be threatening people with a court order. You shouldn't be threatening people with child protective services and that we're going to take away your children. I mean, if you listen to episodes 1 and 2 of this podcast, season 1, episode 1 and 2, you'll see that all of those things happened with Esther. She was threatened with a court order. They actually went and got a court order on her behalf. She had police looking for her. She had a psychiatric evaluation. She was concerned. I don't think anyone ever explicitly threatened to take away her kids, but she, of course, was very worried about that when she saw the case building against her. So even though this is the ethical standard, this still happens, which is why it's so important for people to understand what are the ethical foundations of healthcare and how should it play out and how should it not play out. So that way, whether you are someone who is working the L&D floor or you are a birthing parent, you're aware of what the right thing to do is, and you can be that voice in the room to say, hey, this is unethical. The decision is ultimately the birthing person's. Do they need to understand the risks and benefits? 1,000%. And that needs to be based on accurate information, and the ultimate decision is theirs. Eliciting the patient's reasoning, lived experience, and values is critically important when engaging with a pregnant woman who refuses an intervention that the obstetrician-gynecologist judges to be medically indicated for her well-being, her fetus's well-being, or both. Medical expertise is best applied when the physician strives to understand the context within which the patient is making her decision. Now, this can get a little bit tricky because I think of the fact that most obstetrician-gynecologists recommend a repeat cesarean for everyone in their care, regardless of the clinical situation. I just had someone leave a comment on social media how they'd had a vaginal delivery, then they had a C-section, Then they had another vaginal delivery. Now they're pregnant again, and their provider is recommending that they have another C-section because they had a prior C-section. And it's like, wait a sec. You are someone who has had not only a vaginal birth, but then a VBAC. You have had 2 prior vaginal births. People with 2 prior vaginal births have incredibly high VBAC odds. So unless there is some medical indication which would indicate a repeat cesarean, the idea of having a repeat cesarean just because you've had a prior cesarean, that's not evidence-based care. And this particular patient didn't want a C-section, and that is her informed choice. So that is a little bit of the push and pull that I feel when I read things like that. Obstetrician gynecologist judges to be medically indicated for her well-being. That is really subjective. So we've got to keep that in mind, that there are biases in play when we have the administration of healthcare. And there are biases at play when providers make specific recommendations, especially when someone has a prior cesarean. Okay, next recommendation. When working to reach a resolution with a patient who has refused medically recommended treatment, consideration should be given to the following factors: the reliability and validity of the evidence base, the severity of the prospective outcome, the degree of burden or risk placed on the patient, the extent to which the pregnant person understands the potential gravity of the situation or the risk involved, and the degree of urgency that the case presents. Ultimately, however, the patient should be reassured that her wishes will be respected when treatment recommendations are refused. And yes, all of that is key. Absolutely. They need to understand what are the risks at play, how likely they are to occur, so they can make an informed decision. But that last statement is the important thing that we need to be focusing on here. The person should be assured it is their right. The outcome is their responsibility, because with the right to make that decision comes the responsibility for the outcome, but ultimately it is their right to refuse. Obstetrician gynecologists are encouraged to resolve differences by using a team approach that recognizing the patient in the context of her life and beliefs, and to consider seeking advice from ethics consultants when the clinician or the patient feels that this would help in conflict resolution. The college opposes the use of coerced medical interventions for pregnant women, including the use of the courts to mandate medical interventions for unwilling patients. Principles of medical ethics support obstetrician gynecologists' refusal to participate in court-ordered interventions that violate their professional norms or their consciences. However, obstetrician gynecologists should consider the potential legal or employment-related consequences of their refusal. Although in most cases such court orders give legal permission for, but do not require obstetrician gynecologists' participation in forced medical interventions, obstetrician gynecologists who find themselves in this situation should familiarize themselves with the specific circumstances of the case. Next recommendation. It is not ethically defensible to evoke conscience as a justification to attempt to coerce a patient into accepting care that she does not desire. Next recommendation. The college strongly discourages medical institutions from pursuing court-ordered interventions or taking action against obstetrician gynecologists who refuse to perform them. Final recommendation from the very top of the document. Resources and counseling should be made available to patients who experience an adverse outcome after refusing recommended treatment. Resources also should be established to support debriefing and counseling for healthcare professionals when adverse outcomes occur after a pregnant patient's refusal of treatment. That last statement, I'd like to hear from you. Does your facility offer that kind of support? What does it look like? I would love to know, because I know there are some hospitals that do offer this level of support, and I really want to show the hospitals that don't what that looks like. So please share in the comments. You can email me. I'd love to highlight some stories on the show of how we can best support clinicians after an adverse outcome and how other hospitals can implement similar support systems and what are the best practices for those types of support systems. So again, if your facility offers this, please reach out to me. You can leave a comment. You can go to vbacfacts.com/podcast and let me know, because I would love to highlight some of these stories so more hospitals can more effectively support their clinicians. And so clinicians aren't carrying that level of trauma with them into their next patient. Okay, so let's read what ACOG has to say about refusal of treatment. When a pregnant woman refuses or chooses not to follow medical recommendations, there can be a range of minor to major risks to the patient or to the fetus. In certain situations, a pregnant woman might refuse therapies that the medical professional believes are necessary for her health or survival, that of her fetus, or both. Examples of these situations include a pregnant woman refusing to treat a fetal condition or infection in utero, or to undergo cesarean delivery when it is thought to be medically necessary to avoid an adverse fetal or maternal outcome. Again, this whole statement, this whole paragraph, this whole concept is based on the notion that we have providers who are ethically practicing medicine. And when we look at the top 3 reasons why primary cesareans occur, anyone know what they are? First is malpresentation. Second is non-reassuring fetal heart tones. Third is failure to progress. When we look at failure to progress, even though we have criteria that people need to meet to be issued that diagnosis, often they don't meet that criteria. And we've talked about that before. One study found that over half of the people who had a cesarean for FTP, failure to progress, were not 6 centimeters, which is one of the criteria they need to meet in order to receive that diagnosis. Non-reassuring fetal heart tones, that's another one. When that C-section is called, can vary dramatically. So again, we have what is ethically right, and we have what happens in real life. It can feel very black and white here in this document, but when we look at how medicine is actually practiced and how healthcare is actually administered, it does vary quite a bit. So let's go back to what ACOG says. Such cases can be distressing for the healthcare team. Obstetrician gynecologists may feel deep concern for the pregnant woman and fetus entrusted to their care, worry about the pregnant woman's reaction if a potentially unavoidable adverse outcome occurs, or be apprehensive regarding liability issues resulting from an adverse outcome. Okay, let's pause. So, as you may know, I presented a 1-hour training at the Minnesota affiliate of the ACNM conference, all about how to improve VBAC access and outcomes while decreasing litigation risk. And there are multiple steps that people can easily employ. And as we layer on each step, that provides an additional layer of protection against legal liability. And one of those things is ensuring that the pregnant person understands that this decision carries the weight of the ultimate outcome. Back to the document. Members of the health team may disagree about case management and feel uneasy about their roles or even express moral distress. In these circumstances, as in all clinical encounters, the obstetrician-gynecologist's actions should be guided by the ethical principle that adult patients who are capable decision makers have the right to refuse recommended medical treatment. This doctrine has evolved through legal cases, regulations, and statutes that have established the requirements of informed consent to medical treatment in order to affect patient self-determination and preclude violations of bodily integrity. Informed refusal is the corollary of the doctrine of informed consent. It is an ongoing process of mutual communication between the patient and the physician and enables a patient to make an informed and involuntary decision about accepting or declining medical care. The informed consent process ideally begins before decision-making so that the patient is able to make an informed choice, i.e. informed consent or informed refusal, based on clinical information, the patient's values, and other considerations of importance to her. Voluntariness is a background condition of informed consent, right? The opportunity for someone to choose option A or option B and have that choice freely made and without the added pressure of coercion. So back to what ACOG says. As noted in Committee Opinion number 439, Informed Consent, consenting freely is incompatible with being forced or unwillingly pressured by forces beyond oneself. It involves the ability to choose among options and select a course other than what may be recommended. Pregnancy is not an exception to the principle that a decisionally capable patient has the right to refuse treatment, even treatment needed to maintain life. Therefore, a decisionally capable pregnant woman's decision to refuse recommended medical or surgical interventions should be respected. Okay, so now we're going to dive into the complexities of refusal of medically recommended treatment during pregnancy. So we've talked about the foundation, we've gotten the big bird's eye view of this issue, but let's dive in deeper. So in obstetrics, pregnant women typically make clinical decisions that are in the best interest of their fetuses. Now, I think that statement, again, is filled with judgment, right? Because one person might say, I want to plan a VBAC. Another person might say, that small increased risk to my fetus is unacceptable to me. And so I am willing to accept the other set of risks that are associated with repeat C-sections. Which person is right and which person is wrong? There is no right and wrong here. There is only a set of risks and benefits in VBAC and a set of risks and benefits in repeat cesarean, and people make an informed decision and select which risks and benefits are most acceptable to them. Let's continue with what ACOG says. In most desired pregnancies, the interests of the pregnant woman and the fetus converge. However, a pregnant woman and her obstetrician gynecologist may disagree about which clinical decisions and treatments are in her best interest and that of the fetus. As with a non-pregnant patient, a pregnant woman may evaluate the risks and benefits of recommended medical treatment differently than her obstetrician gynecologist, and therefore may refuse recommended therapies or treatments. Again, that OB might have chosen to have multiple prior cesareans. That might have been the right decision for them. But just because that was the right decision for them, and they may even make that recommendation to their client, that doesn't mean that that's the right decision for the client. Okay, let's continue with ACOG. Such refusals are based not only on clinical considerations, but also on the patient's roles and relationships. They reflect her assessment of multiple ongoing interests, her own, those of her developing fetus, and those of her family or community. Special complexities are inherent in a woman's decision to refuse recommended medical treatment during pregnancy because of the presence of the fetus. The maternal-fetal relationship is unique in medicine because of the physiologic dependence of the fetus on the pregnant woman. Moreover, therapeutic access to the fetus occurs through the body of the pregnant woman. A joint guidance document from the College and the American Academy of Pediatrics states that any fetal intervention has implication for the pregnant woman's health and necessarily her bodily integrity, and therefore cannot be performed without her explicit informed consent. The emergence over the past 4 decades of enhanced techniques for imaging, testing, and treating fetuses has led some to endorse the notion that fetuses are independent patients with treatment options and decisions separate from those of pregnant women. Although the care model that fetuses are independent patients was meant to clarify complex issues that arise in obstetrics, many writers have noted that it instead distorts ethical and policy debates. And I would say yes, because the second that any entity is able to come in on behalf of that fetus and override the wishes of the mother, that's a problem. Because the mother, and as any person, should have the right and does have the right to make any medical decision about their body and what happens to their body and inside their body, and they should be the one to make that decision rather than some outside force, whether that is the physician or the court. Let's return back. When the pregnant woman and fetus are conceptualized as separate patients, the pregnant woman and her medical interests, health needs, and rights can become secondary to those of the fetus. Exactly. That's what I just said, and that is the crux of the issue. At the extreme, construing the fetus as a patient sometimes can lead to the pregnant woman being seen as a fetal container rather than an autonomous agent. Yes, That is the problem. In one example, researchers performing fetal surgery, interventions to correct anatomic abnormalities in utero, have been criticized for their failure to assess the effect of surgery on the pregnant woman who also undertake the risks of the surgical procedures. The most suitable ethical approach for medical decision-making in obstetrics is one that recognizes the pregnant woman's freedom to make decisions within caring relationships, incorporates a commitment to informed consent and refusal within a commitment to provide medical benefits to patients, and respects patients as whole and embodied individuals. This ethical approach recognizes that the obstetrician-gynecologist's primary duty is to the pregnant woman. This is so key for people to hear. Because again, as ACOG said in the abstract, there can be this push and pull between, well, what is the best for the woman? What is best for the fetus? And here it's very clear. The OBGYN's primary duty is to the pregnant woman. This duty most often also benefits the fetus. However, circumstances may arise during pregnancy in which the interests of the pregnant woman and those of the fetus diverge. Okay, so what does ACOG say you should do? Let's see. These circumstances demonstrate the primacy of the obstetrician-gynecologist's duty to the pregnant woman. For example, if a woman with severe cardiopulmonary disease becomes pregnant and her condition becomes life-threatening as a result, her obstetrician-gynecologist may recommend terminating the pregnancy. This medical recommendation would not make sense if the obstetrician-gynecologist was primarily obliged to care for the fetus. ACOG continues. Instead, it is more helpful to speak of the obstetrician-gynecologist as having beneficence-based motivations towards the fetus of a woman who presents for obstetric care, and a beneficence-based obligation to the pregnant woman who is the patient. Now, beneficence refers to something that is a charitable act, something that puts the desires of someone else first. So the intervention on behalf of the fetus must be undertaken through the pregnant woman's body. Thus, questions of how to care for the fetus cannot be viewed as a simple ratio of maternal and fetal risks, but should account for the need to respect fundamental values, such as the pregnant woman's autonomy and control over her body. You can see why I wanted to cover this document so early on in the podcast. And you can see again why this topic generates some of the most lively conversations and exchanges. And not only just lively, but important. Because these kind of circumstances rise quite frequently. And whether we're talking about a situation where it feels very immediate or a situation where you still have time, these kinds of conversations, these kinds of interactions occur all the time in healthcare. And so I really appreciate this document from ACOG that lays it out very clearly. Who does the obstetrician-gynecologist serve? That is the pregnant woman. That is the first and foremost. We do not want her to become a fetal container, as ACOG says. So let's read about what ACOG says about directive counseling versus coercion. So when a physician is faced with a situation in which a patient refuses a medical recommendation, it is useful to distinguish the use of directive counseling from efforts aimed at coercion. Okay, so let's see. What does ACOG say directive counseling is? Directive counseling is defined as patient counseling in which the obstetrician-gynecologist plays an active role in the patient's decision-making by offering advice, guidance, recommendations, or some combination thereof. That's directive counseling. Coercion is defined by the practice of compelling someone to do something by using force or threats. Directive counseling often is appropriate and typically is welcomed in the medical encounter because medical recommendations, when they are not coercive, do not violate, but rather enhance the requirements of informed consent. And of course, we always want to hear, what is the recommendation of the provider? That is a vital part of the informed consent process because we can look objectively at the risks and benefits of a specific decision, But then we always need to bring in the current clinical situation, the clinical history of the patient. How do those risks and benefits apply in this specific circumstance? And that's where getting the recommendation of the clinician and hearing why do they make these recommendations is important. Let's go back. However, if a patient refuses the recommended course of care, it is vitally important that physicians recognize when they cross the line that separates directive counseling from coercion. Good intentions can lead to inappropriate behavior. And I think that is so important for us to just pause. Good intentions can lead to inappropriate behavior. So often, we aren't talking about bad people here. We're talking about people who have good intentions. So let's keep that in mind. They think they're doing the right thing. In fact, from their heart, they're doing the right thing. Let's go back. The use of coercion is not only ethically impermissible, but also medically inadvisable because of the realities of prognostic uncertainty and the limitations of medical knowledge. Pause for a sec. When we talk about limitations of medical knowledge, the first thing that comes to mind for me is higher order VBACs. So someone who wants to have a VBAC after 3, 4, 5, 6 cesareans. If you're familiar with our work, you'll know that we've done a whole article on this topic up on the website. We have a training within VBAC Facts professional membership on this topic. And the thumbnail is, we have limited evidence. We don't have solid evidence on the risks and benefits of vaginal birth after 3 or more cesareans. And so that is a situation of limited knowledge. And so that's exactly what ACOG is saying here, limitations of medical knowledge. Sometimes we don't have high quality evidence. Okay, let's go back. As such, it is never acceptable for obstetrician gynecologists to attempt to influence patients towards a clinical decision using coercion. Obstetrician gynecologists are discouraged in the strongest possible terms from the use of duress, manipulation, coercion, physical force, or threats, including threats to involve courts or child protective services to motivate women towards a specific clinical decision. Now, this statement is in the abstract. It's so important that we're reiterating it here because every single person involved in healthcare and every single person in the room at the moment these conversations are happening needs to be aware of that statement. So that way we can all hold each other accountable when we cross that line of saying, well, I'm going to have to engage the courts. Well, why don't we have social services come in and talk to you? Well, why don't we have a psychiatrist come in and give you a psychiatric evaluation? That is all counter to what ACOG says. And so it's important for everyone to be aware that this is the ethical foundation so we can all hold each other accountable and provide the best healthcare, respectful healthcare. Back to what ACOG says. Although the physician aims to provide recommendations that are based on the best available medical evidence, data and technology are imperfect, and responses to treatment are not always predictable for a given patient. As such, it is difficult to determine the outcome of treatment or lack of treatment with absolute certainty. It requires a measure of humility for the obstetrician gynecologist to acknowledge this to the patient and to herself or himself. Again, let's pause and talk about this. This again goes back to this concept that I keep returning to, which that is the obstetrician, gynecologist, the midwife, the nurse, all of these clinicians are lifeguards. They're all there to respond in the event of a medical emergency, to guide the pregnancy and the delivery, and be there in the event that something goes off course from normal. But no one is capable of entirely preventing a bad outcome, and no one can see into the future and know how a specific labor will play out. And so this is a moment to have some kindness towards your heart if you are a clinician, if you are a healthcare provider, and recognize that you can show up and provide the best care and still have a bad outcome. Let's go back. Because of the potential inability to determine with certainty when a situation will cause harm to the fetus, as well as the potential inability to guarantee that the pregnant woman will not be harmed by the medical intervention itself, a balance of potential outcomes that addresses the pregnant woman and her fetus should be presented. The obstetrician gynecologist should affirm the importance of the pregnant woman's assessment of her relational interests, personal, familial, social, or community, and acknowledge prognostic uncertainty. In addition, the following should be acknowledged: the limitations of the patient's understanding of her clinical situation, cultural, social, and value differences, power differentials, and language barriers. When working to reach a resolution with a patient who has refused medically recommended treatment, consideration should be given to the following factors: the reliability and validity of the evidence base, the severity of the prospective outcome, the degree of burden or risk placed on the patient, the extent to which the pregnant woman understands the potential gravity of the situation or the risks involved, and the degree of urgency that the case presents. Ultimately, however, the patient should be reassured that her wishes will be respected when treatment recommendations are refused. When a pregnant patient refuses recommended medical treatment, the physician should carefully document the refusal in the medical record. Examples of important information to document are as follows. There are 3 different things here. The need for the treatment has been explained to the patient, including discussion of the risks and benefits of the treatment, alternatives to treatment, and the risks and possible consequences of refusing the recommended treatment, including the possible risk to her health or life, the fetus's health or life, or both. 2, the patient's refusal to consent to a medical procedure or medical treatment. 3, reasons, if any, stated by the patient for such refusal. Next section is entitled Arguments Against Court-Ordered Interventions. Again, this is so key. This does happen. I did a whole presentation years ago at the American Association of Birth Centers conference on this very topic of court-ordered cesareans. And I think people are really shocked because just like that case that happened this past summer in Israel and the resulting Israeli Supreme Court ruling that cesareans cannot be coerced, that's not something I saw in the news. And so whether cases like this actually hit the news or not, and whether we hear about them or not, of course, impacts our perception of how frequently they happen. They absolutely happen. So let's see what ACOG says. When the obstetrician gynecologist and the patient are unable to agree on a plan of care, and a pregnant woman continues to refuse recommended treatment, some OBGYNs, hospital staff, or legal teams have attempted to force compliance through the courts, most notably for cesarean delivery or blood transfusion. Court-ordered interventions against decisionally capable pregnant women are extremely controversial. They exploit power differentials, involved incursions against individual rights and autonomy, and manifest as violations of bodily integrity and often gender and socioeconomic equality. The college opposes the use of coerced medical interventions for pregnant women, including the use of the courts to mandate medical interventions for unwilling patients. Principles of medical ethics support OBGYN's refusal to participate in court-ordered interventions that violate their professional norms or their consciences. Again, this could be a whole topic, but I have a little bit of a challenge with that because say an OBGYN does not want to attend a vaginal birth after 3 cesareans. Do they have the right to say, I'm not going to do that? I'm really curious to hear what you have to say. Here's my thought. I mean, if they are in a hospital and they have an L&D unit, they attend labors, they either have a team on site or they're a rural community and they have protocols to attend emergencies, as any hospital should that has a labor and delivery unit, all of those same policies, procedures, and protocols would kick in whether someone has no prior cesareans or 3 prior cesareans. So to say, well, I don't feel comfortable doing this, so does that then mean that now the only option is for the person who wants to labor to now have a C-section because the OB doesn't feel comfortable? That's the problem. So I'm really curious to hear what you have to say about this. Let me know. However, obstetrician gynecologists should consider the potential legal or employment-related consequences of their refusal. Although in most cases, such court orders give legal permission for but do not require OBGYN's participation in forced medical interventions, OBGYNs who find themselves in this situation should familiarize themselves with the specific circumstances of the case. The college strongly discourages medical institutions from pursuing court-ordered interventions or taking action against OBGYNs who refuse to perform them. It is not ethically defensible to evoke conscience as a justification to attempt to coerce a patient into accepting care that she does not desire. Okay, prognostic uncertainty. That's that whole concept that we can't see into the future. So this is what ACOG says. Prognostic uncertainty is present to various degrees in all medical encounters across all specialties and is common enough in obstetric decision-making to warrant serious concerns about legal coercion and the tremendous effect on the lives and civil liberties of pregnant women that court-ordered intervention entails. A study of court-ordered obstetric interventions suggested that in almost 1/3 of cases in which the court orders were sought, the medical judgment in retrospect was incorrect. Let me say that again. A study of court-ordered obstetric interventions suggested that in almost 1/3 of cases in which court orders were sought, the medical judgment in retrospect was incorrect. 1/3 of cases. That's significant. Okay, the next section, barriers to needed care. ACOG says coercive and punitive policies are potentially counterproductive because they are likely to discourage prenatal care and successful treatment while undermining the physician-patient relationship. Attempts to criminalize pregnant women's behavior may discourage women from seeking prenatal care. Likewise, court-ordered interventions and other coercive measures may result in fear of the patient's part about whether her wishes in the delivery room will be respected, which could discourage the pregnant patient from seeking care. Therefore, when the obstetrician-gynecologists participate in forced treatment of their pregnant patients, outcomes for the patients and the fetuses may worsen rather than improve. And I see this dynamic play out quite frequently, where people just opt out of the healthcare system. They stop going to their prenatal care. People who completely lose trust in their healthcare provider, they are fearful that their physician will find some, quote, medically valid reason for them to need a C-section, when in reality, they don't. That impacts outcomes. That impacts healthcare. People should have access to respectful healthcare that honors their right to make their own informed decision-making. Okay, discriminatory effects. ACOG continues. Coercive policies directed towards pregnant women may be disproportionately applied to disadvantaged populations. In cases of court-ordered cesarean deliveries, for instance, most court orders have been obtained against women of color or of low socioeconomic status. Yes. In a review of 21 court-ordered interventions, 81% involved women of color, and 24% involved women who did not speak English as a first language. Likewise, a systematic review of more than 400 cases of coercive interventions found that most included allegations against low-income women. The inclusion of an ethics committee or a patient advocate would help mitigate the disproportionate application of coercive policies to certain subpopulations of women and should be made available whenever possible. So, the process for addressing refusal of medically recommended treatment during pregnancy. What do you do? If you are a provider, if you are a clinician, what do you do when someone refuses your recommendation? And a court-ordered cesarean, a psychiatric evaluation, and calling social services is off the table. So what do? This is really important. Let's walk through it together. ACOG says, although there is no universal approach to communicating with and caring for a pregnant patient who refuses medically recommended treatment, steps can be taken to mitigate conflict, diffuse intense emotions, and encourage consideration of the patient's perspective. These steps may create space, even under time constraints, to ensure that patients are fully heard and considered. Let's take a moment to talk about what that means. When we look at people who report their births as being traumatic, or who even develop things like PTSD after their birth, one of the things they report is that they did not feel heard. They felt like their viewpoint was completely overridden. They used terms like they felt like their body was a slab of meat that someone else was doing things to, like they weren't even part of their body, because it's like what they wanted was completely ignored. And the only thing that mattered was the clinician, the provider doing what they felt like needed to be done. And that loss of control, that overriding of something so intimate like your healthcare decisions, especially regarding pregnancy and childbirth, for many women, especially those who are sexual assault survivors, this can be especially triggering. So we always need to keep in the back of our mind the fact that about 1 in 3 women in the US have endured a sexual assault. And when we couple that with the instance of healthcare, especially pregnancy care, we always have to remember that in the back of our mind. It's very likely the person sitting in front of you has survived some sort of sexual assault. And to keep that in mind when we're talking about healthcare options, recommendations, and how we engage with them. So, step 1, seek to understand the patient's perspective. So ACOG says, eliciting the patient's reasoning, lived experience, and values is critically important when engaging with a pregnant woman who refuses an intervention that the obstetrician gynecologist judges to be medically indicated for her well-being, her fetus's well-being, or both. Medical expertise is best applied when the physician strives to understand the context within which the patient is making her decision. The OBGYN should acknowledge the importance of the pregnant woman's knowledge and values while making medical recommendations. A pregnant woman's decision to refuse treatment may be based on religious or cultural grounds, her assessment of the converging interests of herself, her fetus, her family, or her community, a misunderstanding of the clinical situation, or the experience of a family member or friend. Determining the basis for a pregnant woman's decision to refuse medically recommended treatment enables the physician to address her concern or understand its importance to her, and then take steps towards resolution. To that end, effective communication skills and strategies are critically important. Use of empathetic statements, listening without interrupting, and taking a short break before revisiting the case can help diffuse tensions, foster a calmer atmosphere, and establish trust. Now, they reference the RESPECT model, which we'll talk about that a little bit more. The RESPECT model is an example of one tool that can be used to help optimize patient-centered communications. Physicians are also referred to additional college resources that can relate to effective communication, cultural sensitivity, empathy, and health literacy. I just want to quickly go through what the RESPECT communication model entails. Okay, so RESPECT, let me break this down here. RESPECT is rapport, empathy, support, partnership, explanations, critical competence, and trust. So rapport, connect on a social level, see the patient's point of view, consciously suspend judgment, recognize and avoid making assumptions. Empathy, remember that the patient has come to you for help. Seek out and understand the patient's rationale for her behaviors or illness. Verbally acknowledge and legitimize the patient's feelings. Support, ask about and understand the barriers to care and adherence. Help the patient overcome barriers. Involve family members if appropriate. Reassure the patient that you are and will be able to help. Partnership, be flexible with regard to control issues. Negotiate roles when necessary. Stress that you are working together to address health problems. Explanations, check often for understanding. Use verbal clarification techniques. Cultural competence, respect the patient's cultural beliefs. Understand that the patient's view of you may be defined by ethnic or cultural stereotypes. Be aware of your own cultural biases and preconceptions. Know your limitations in addressing medical issues across cultures. Understand your personal style and recognize when it may not be working with a given patient. Trust. Recognize that self-disclosure may be difficult for some patients. Consciously work to establish trust. Now again, that's the respect communication model: rapport, empathy, support, partnership, explanations, cultural competence, and trust. Okay, enhance the patient's understanding. Just as the patient must be free of external constraints on her freedom of choice, so must she be free of misinformation regarding the clinical factors on which the physician's medical recommendations are formulated. Adequate disclosure of relevant information may include that which is common to the practice of the profession, the reasonable needs and expectations of an ordinary patient, and ideally, the needs and expectations of the patient making the decision. It also is important to inform the patient that other aspects of her care are not conditioned on making a choice that her obstetrician-gynecologist might prefer. Forthright and transparent communication of clinical information should encompass the range of clinical options available to the patient, including the potential risks, benefits, and consequences of each option and the likelihood of achieving goals of care. The discussion should include the treatment option that the patient prefers, as well as the benefits, risks, and consequences of no treatment or alternative treatments. Acknowledging that the patient is free at any time to refuse or withdraw her consent is an important part of the discussion. And I would add and just specify that just because someone signs a consent upon admission to the hospital, that doesn't mean you have now given away your consent forever and always. You are always able to go back and say, you know what, I know I signed XYZ, but I've changed my mind. I don't want to do that anymore. Now I want to do this. So just because someone signs that paper, that doesn't mean they're now locked in. And ACOG reiterated that here. However, the physician should attempt to give the patient as much information as possible so that she has a basic understanding of her clinical situation and the implications of not receiving the treatment. Ideally, after the patient and the physician have discussed the clinical situation and the benefits and risks of the recommended treatment or intervention, the patient should decide whether or not to proceed with the recommended treatment, informed consent, or to forego the recommended treatment, informed refusal. Efforts to enhance patient understanding of relevant clinical information include the use of lay language rather than technical jargon. Can I just pause there for a second? Those of you on my email list know that I recently supported my dad through a total reverse shoulder replacement. And it was astonishing to me, some of the paperwork he received that included technical jargon that we were Googling to try to figure out what it meant. And these were handouts that he received. It is so important that when any sort of patient education is written, and whether that's patient education that is written down or it's patient education that's verbal, that we're very clear to define terminology. I personally love to use the actual terminology in my trainings and then provide the definition. So that way, if people come across that word again, they already have an education on what it means. They're already familiar with it. But I'm really hesitant to just dive in to jargon and not provide a definition because we're making a lot of assumptions about what people know. And I was highlighting that handbook and intended to go back and say, hey, this particular section is not helpful because you are using language that your typical person doesn't know. I'm a pretty educated person. If I don't know this language, I'm telling you, the bulk of the people who are receiving this don't know it either. And we're busy doing the post-op and we're busy getting ready for this surgery and we're having to Google things to figure out what it is that they mean. So really important to be aware when we're using jargon to define very clearly what those words mean. So continuing on, so we're talking about efforts to enhance patient understanding. Discourse in or translation to the patient's primary language if the patient's proficiency in English is limited. Use of educational materials such as those developed by the college and efforts to mitigate patient stress. Most important is the acknowledgement that informed consent is an ongoing process, not an event or a signature on a document, and involves a willingness on the part of the obstetrician gynecologist to engage in open, non-judgmental, and continued dialogue. Okay, next section. Determine the patient's decisional capacity. ACOG says, a pregnant woman's decision to refuse medically necessary treatment may occasion questions regarding her decisional capacity. Patients are, by law, presumed to be decisionally capable unless formally determined otherwise. The OBGYN should not infer from a patient's decision to refuse treatment that the patient's capacity to make medical decisions about proposed care is diminished. Exactly. And this is what happened in season 1, episodes 1 and 2 with Esther when social services got involved with her pregnancy. And they said, oh, well, she's doing something that's outside of the norm, so therefore she must have some sort of diminished capacity. Let's do a psychiatric evaluation on her to ensure that she is of her right mind. And just because someone makes a different decision doesn't mean they're not of their right mind. It just means they're working off of a different set of values. It means they receive the risks and benefits at play in a different way. So back to what ACOG says, disagreement with a physician's recommendation is not per se evidence of decisional incapacity. Although psychiatric consultation may justifiably be sought when a pregnant woman's decision-making capacity, i.e., her capacity to understand her options and appreciate the potential consequences of her choice, is in question, in no circumstance should a psychiatric evaluation be used as a punitive measure or viewed as a means to coerce a patient into making a specific decision. Genuine differences in how OBGYNs and patients assess and balance risk, the pregnant woman's assessment of the collective interests of herself, her fetus, her family, or her communities, and religious beliefs and cultural meanings of interventions may all lead decisionally capable patients to choose options other than those strongly recommended by their OBGYN. When a patient has been determined to lack decisional capacity, the decisions of her legally authorized surrogate generally should be honored. Such decisions should reflect the patient's previously expressed values and preferences when these are known. Emergency cases. I just want to briefly comment on this before we dive in. One of the topics that gets brought up sometimes is what do you do in emergency situations? As I've had numerous nurses express, there is always time for a very, very, very quick, this is what's happening. There's always time to keep the patient updated on what's happening. There's always time, even if it is just super quick. But there shouldn't be a circumstance where something is happening to the patient and they're totally unaware. Someone in that room should be communicating to the patient what's happening and making sure that they always know every step of the way that they can make a different choice. So emergency cases, decision-making. So let's see what ACOG says. Decision-making can be particularly difficult and emotionally charged in emergency scenarios. Emergency cases may raise two distinct problems. First, fully informing the patient may not be possible. Nevertheless, a patient retains the right to make an uninformed refusal. Even if the patient has not been fully informed, a decisionally capable adult patient's refusal of emergent care should be respected. And I remember having an exchange with someone on this very topic, and she was a nurse, and her feeling was if the patient wasn't fully informed, they didn't have the right to make the decision. And that's why I think documents like this are so important, because even if the patient isn't fully informed, they still have that right. Second, the patient may be incapacitated and therefore unable to consent for herself. Presumptive consent for critically needed care for a patient can sometimes be used, but only if it is critically necessary to proceed with care immediately and a patient's preference is not known. Use of presumptive consent is limited to emergency clinical situations in which the patient is completely decisionally incapable and no surrogate decision maker is reasonably available. Presumptive consent applies to cases in which an unconscious patient has not indicated a preference for treatment. Circumstances should support a reasonable presumption that the patient would retrospectively endorse the intervention. Expressions of disagreement or unwillingness preclude presumptive consent. A previously documented or expressed refusal should be respected. Next section. Evaluate maternal and fetal risk. Risk assessment during pregnancy poses unique challenges to patients and physicians. Interventions recommended during pregnancy and childbirth may reflect distortions of risk based on concerns about failure to intervene rather than robust considerations of risks associated with those interventions. Risk assessment in the context of a pregnant woman's refusal of recommended treatment should address concerns regarding the respective benefits of the procedure to the pregnant woman and the fetus, the probability of harm to the pregnant woman and the fetus from either performing or withholding the procedure, and the risks and benefits of less intrusive treatments when available. Interdisciplinary team approach. ACOG says, obstetrician-gynecologists are encouraged to resolve differences by using a team approach that recognizes the patient in the context of her life and beliefs, and to consider seeking advice from ethics consultants when the clinician or the patient feels that this would help in conflict resolution. The team may include colleagues from other disciplines such as nursing, social work, chaplains, or ethics consultation. With the patient's consent, it also may be helpful to include in the discussion members of the pregnant woman's personal support network. However, these individuals cannot make the decision for the decisionally capable patient. Obstetrician-gynecologists are encouraged to consider seeking an ethics consultation and to discuss the clinical situation with their colleagues. A team approach can help increase the likelihood of realliance with the patient by underscoring the patient's concerns are shared among the healthcare team and her personal support system, particularly when the patient is included in the decision to use this collaborative approach. Okay, final section. Supporting the patient and the healthcare team when adverse outcomes occur. ACOG says, when adverse outcomes occur after a pregnant patient's decision to refuse recommended treatment, she may feel guilty about her decision, and members of the healthcare team may experience frustration and moral distress about whether they took all possible preventative measures. As with any adverse outcome, it is important that the patient and healthcare team members engage in honest communication and receive compassionate support. Resources and counseling should be made available to patients who experience an adverse outcome after refusing recommended treatment. Patients can be reminded that medical decision-making is complex and that well-intended people can make decisions they regret. The fact that the adverse outcome was not a certainty should be reinforced. Most critically, the clinical team's efforts should be directed towards helping the woman with any grief that she may experience. Judgmental or punishing behaviors regarding the patient's decision can be harmful. Resources also should be established to support debriefing and counseling for healthcare professionals when adverse outcomes occur after a pregnant patient's refusal of treatment. I think that is so important. And again, if your facility has resources, has a program in place, I would love it if you would reach out and share with me what that looks like. Do you reach out to the resources? Do the resources reach out to you? What resources are available? How are they administered? Again, I want to show various hospitals around the country what is possible and the various ways these levels of support can be implemented. We care for our clinicians, right? We want them to be cared for too. Back to what ACOG says, medical practitioners can be reminded that respecting and supporting patients' autonomy is a core ethical principle, even when it involves risks of adverse outcomes. Yes. Clinician grief and anger are understandable, but these feelings need to be processed outside of interactions with the patient. As with any adverse outcome, debriefing in a supportive context should be undertaken to identify any measures that would help in future cases. Yes. So here is the conclusion. One of the most challenging scenarios in obstetric care occurs when a pregnant patient refuses recommended medical treatment that aims to support her well-being, her fetus's well-being, or both. Such cases call for an interdisciplinary approach strong efforts at effective medical communication, and resources for the patient and the healthcare team. The most suitable ethical framework for addressing a pregnant woman's refusal of recommended care is one that recognizes the interconnectedness of the pregnant woman and her fetus, but maintains as a central component respect for the pregnant woman's autonomous decision-making. This approach does not restrict the OBGYN from providing medical advice based on fetal well-being, but it preserves the woman's autonomy and decision-making capacity surrounding her pregnancy. Pregnancy does not lessen or limit the requirement to obtain informed consent or to honor a pregnant woman's refusal of recommended treatment. A great document. Again, I will include a link to that document in the show notes. And also, I would love to hear from you. Do you have a story to share about informed refusal? If so, let me know. Go to vbacfacts.com/podcast, share your story there, and I may share it on a future episode. So until next time, I'm Jen Kamel, founder of VBAC Facts, and don't forget what we are about. Since 2007, our focus has been to provide objective and accurate information on vaginal birth after cesarean and repeat cesarean to parents, professionals, policymakers, and the court, so all decisions can be informed, ethical, and just. I'll see you next time.